All right, before we get started on the show, first off, welcome. Welcome to the program. You made it to Wednesday. Congratulations. I'm physical therapist Joey McKay. Welcome to PT Pintcast. We save physical therapists from missing out on amazing insight, remarkable ideas, and motivational stories in the world of physical therapy. Before we get started, we want to let you know to say thanks to one of our newest sponsors at your CBD store. They know that you want to be an up-to-date physical therapist. In order to do that, you need to know what it is, right? I hear from a lot of outpatient PTs that their patients are coming in saying they're taking it, they're trying it, and they want to know how does it change their treatment? How is it going to work inside the body while they're doing other things? The problem is there's so much information out there and so little time. So to find the right information, it can be daunting. All right, so that's why they've done the work for you. Here's what you do. Go to cbdrx4u.com, check out their educational links, and begin speaking confidently and clearly about CBD for your patients. Again, check out the physician-led links at cbdrx4u.com. All right, let's get the show started. I was trying to work in like a joke, like this show's going to be exciting today. We've got some great guests lined up, a pretty good topic. Hopefully it'll keep you awake because we're talking about sleep, but I couldn't find just the right dad joke vibe to get that, but that's what we'll be talking about. Really going to dig into something that we had talked about a while ago. I think it made the rounds sort of like that news cycle around PT Twitter, and that is sleep and how is sleep health integrated into physical therapy. APTA put out a House of Delegates position paper, a position statement on the PT's role in sleep health. We'll talk about that just a little bit. Why is sleep a problem? I don't want to call myself an expert, but most nights I do it. I with no practice, don't even train me. But what can we and should we be looking at in terms of how is this affecting our patient's health and what we as a PT could do about it in our scope of practice, right? What do patients believe is optimal sleep? What do we believe? What does the research say? So that's why we'll bring in today's guests. First, our guest is a physical therapist and full-time educator with Evidence in Motion. He's completing his Doctor of Science in Physical Therapy at Bellin College with a research focus on sleep and pain health. And returning guest as well, an associate professor in the physical therapy and rehab science department and director of the Sleep, Health, and Wellness Lab at the University of Kansas Medical Center. Welcome, Brett Nielsen and Katie Siangsikin. Welcome to the show.
Hey, Jimmy. Thanks for having us.
Guys, welcome back. Before we hit record, you guys are both returning guests. And I had said we've never had you on the show live with this live new broadcast feature, but we had you on, Katie. We had you on via phone, and Brett, we recorded in person at National Student Conclave in Miami, and I was wearing a little bit of a different outfit. Do you want to tell people what the outfit was?
Yeah. I believe it was a Spider-Man costume, and we filmed it from a loud bar at NAC, and it was a blast. It was a lot of fun.
At National Student Conclave Miami. National Student Conclave traditionally had fallen on or around Halloween. I wasn't just walking around wearing full head to toe, by the way, if people couldn't tell, head to toe spandex, which is bold, but Miami was super nice. It was warm. I felt free to wear the spandex outfit. Strangely enough, that was not even the weirdest outfit in that bar. It's Miami. They've got some weird things going on. So welcome back to the show. I'm having, because I've gone full 2020, 2021. The first round, we talk about what we're drinking. We get the hard questions out of the way first. I'm having a Corona. You might as well embrace the suck. So why not just embrace the Corona? So cheers to you guys. You guys having anything tonight? It's Wednesday. What are we drinking?
Well, I'm still at work, unfortunately. Yeah. I was hoping to make it home, but I did not. So I'm drinking some tea. It's not terribly exciting, but it's best I could do at work right now.
It's Pintcast. You can put whatever you want in the pint. It could be beer, it could be tea or coffee. Brett, what do you got?
I'm finishing up work as well. I'm out on the West Coast in Seattle, Washington, so it's maybe a little early, but I'm drinking an Olipop right now. So
okay,
nice, tasty, sparkling tonic beverage. So
that's fine. All right, we call that our first round. We tell you what we're drinking. It's brought to you by our friends from Owens Recovery Science. They're a single source for PTs looking for certification in personalized blood flow restriction rehabilitation training. Johnny Owens and the team. flying around the world and educating professional sports teams, and then clinicians who work outpatient, inpatient. They were just involved in that ESPN story with Alex Smith. Stefania Bell was nice enough to produce that, and talking about how they used BFR in Alex Smith's return from a devastating leg injury all the way back on the field. So find out more about BFR, as the cool kids are calling it these days, at owensrecoveryscience.com. So before we jump into sleep, I just want to discriminate against something. Brett, in your intro, in your bio, we talk about you are currently getting your Doctor of Science in Physical Therapy. That is different than a DPT. That's a DSC PT. I didn't memorize that. I'm reading it. There's a lot of letters there. What's the difference? This is something like I feel like I've seen and just didn't understand, and then I never looked up. But since you're here,
yeah, absolutely. It's a great question, because there's a big misnomer. A lot of people in physical therapy hear about terminal doctorates, and you got to be careful throwing around the word terminal. Especially outside of the PT profession. When I tell my friends and family, oh, I'm doing my terminal doctorate, people are like, whoa, wait a minute. Terminal, is often associated with death, which is, very serious. So, but it is referred to as a terminal doctorate, or more maybe commonly or better, maybe politically correct would be an educational an educational doctorate, right? So it's a doctorate that is focused on more education versus a clinical doctorate, which would be a DPT. So you can think of a DSC on this kind of same platform as a Doctor of Philosophy or a PhD, or Doctor of Education, EDD, et cetera. So
you're just going for it. You're just full out going for it.
Yeah. So, well, it relates to my, what's new in my life. So I actually, the introduction says I'm full-time with Evidence in Motion. I'm still faculty with Evidence in Motion, but I, as of January, have taken a full-time faculty position with the new developing program at Hawaii Pacific University, which will be the very first physical therapy program in the state of Hawaii. So excited about that new opportunity, and really pursuing the DSC is what's kind of led me down that pathway. So
I will extend the olive branch to welcome that program into existence. If you guys ever want to do a live show, I'm willing. Twist my arm to go to Hawaii to do. I mean, back in the olden days when we used to do things in person, like right now as we're recording, it's CSM, and that thing used to be jam packed into a week, and now that's spread out virtually across the month. But when we used to do things in person, we used to go to PT programs. So, well, congratulations, that's great. Build a program, and hey, the first one in an area, that's got to be a great feeling.
Absolutely.
All right, so both of you really have backgrounds in sleep. We've had you on the show before talking about this topic. It's made really the rounds on social media, which I think is a good thing, because it really puts some areas in practice into focus, and sleep being one of them. So let's start off, like, how is sleep health integrated into physical therapy? Most of the times our patients are awake, but we know that recovery does occur, and some parts of recovery occurs while our patients are sleeping. So, Katie, we'll start with you. Why is sleep so important for a physical therapist to pay attention to?
Yeah, I mean, I think that's a great question to start off with. I mean, I think when we think about, kind of the three pillars of optimal health, right? Like we think about good nutrition, we think about exercise, and sleep. Like sleep is a very important pillar of optimal health. And so, as PTs, we tend to focus on the physical activity and the exercise and the rehabilitation from injury. But I think, as we're really doing a better job of looking at the whole person, we really need to make sure that we're talking to them about their sleep health, in addition to nutrition as well. And we really do know that sleep is an incredibly important time when our body is able to heal. So a lot of the patients that we're working with, they have suffered some sort of an injury or, a disease onset. And so if they're not getting optimal sleep, chances are their body is not able to optimally heal, from that injury as well.
Brett, chime in. This is down your alley too, right? Is Katie just hitting all the high notes right there?
Yeah, she's hitting all the high notes, and Katie is absolutely the leading sleep expert in physical therapy by far. I think how I arrived at sleep in developing my interest in it is treating patients in pain, particular. And I practice in an outpatient physical therapy clinic, and was seeing, more complex patient cases. And you start to kind of notice some similar behaviors. And a lot of these patients come in, they're not in good health. They're not eating well, they're not moving. And if you start questioning about it, they're not sleeping well either. And a wise mentor of mine, Dr. Adrian Lowe, for those of you who don't know Adrian, one of the kind of leading experts in pain science, has, said, and I don't know if he was the first one to say it, but he's the one I heard it from, if you can get a patient in pain to sleep, game over. And so I just started recognizing, like, here we are trying to mobilize and get people moving, but what if addressing the foundational issues of health could better prepare people to actually start moving and doing the things that we're trying to get them to do, right? So often in PT, right, we're trying to create behavior change, and sometimes we're beating our head against the wall, right, because we can't quite do that. But what if our patients aren't quite ready for that? And what if we maybe need to start asking better questions or different questions and intervening in a different way to set them up for more success, if you will?
All right. So Katie, let's come back to you. You said optimal sleep, right? So let's say you're talking, and this is a big part of the subjective exam when you can get there. And I bet you sometimes patients kind of just view it as a throwaway, right? Well, why are they asking me about sleep? I'm here because of my shoulder. How do you what are you looking for in those questions when you're working with a patient? What would you advise PTs to ask to be able to measure how optimal their sleep might be?
Yeah, that's a good question, and obviously it depends on how you define optimal, and I think we oftentimes think of optimal in terms of duration, and that certainly is a piece of it, right? The American Academy of Sleep Medicine recommends that adults get at least 7 hours of sleep each night on average for optimal health. So that's a very important piece of the puzzle. So I think, that's a great place to start, is on average, how much sleep are you getting, at night? But we can't overlook quality either, because you could sleep for 8 hours and be getting really terrible sleep. So I like to ask, my patients, how would you describe your sleep quality, and leave it open-ended. If you want to, you could say, would you say it's very good, very bad, or, somewhere in between. I like to have people describe it, because the words that they use is often very eye-opening. So duration and quality. And then two, I think getting some sort of an idea of, how long have these sleep issues been going on? Is it because of their injury or the reason that they're coming to see you, the physical therapist, or have they been having a sleep issue for a longer time? Because then you're starting to think about, could they have an underlying sleep disorder where they really need to be referred for further assessment? Or is it because, like Brett said, that they, if they've had surgery or they're having pain, and if you're able to calm that pain and address the issue that they're why they're seeing you, in addition to talking about, prompting good sleep health, I think that you might have a slightly different way of, talking to your patients about sleep issues.
Sometimes you might be the first medical professional who really spends more than 5 minutes on it.
Absolutely. And I think that's something that, people will probably tend to find, is that, I've had so many of the people that I work with where they'll say things like, gosh, you're the first person in 10 years that has asked me about my sleep. Like, it's not being asked by their physician, by their nurse, by the other healthcare providers, and not to, to throw those people under the bus, because, oftentimes these individuals have, other things that are going on, and that's why they're seeing that individual, but if no one's asking them about their sleep, then obviously it's going, unaddressed and untreated, right? And so why not physical therapists? It's certainly within our scope of practice to start that conversation and to give education on ways that those individuals can optimally, sleep better.
Brett, you brought up what Adrian Lowe had said. If you can get someone in chronic pain to sleep, like, game over. So it kind of begs the question, right? Is it chicken or the egg? Are the sleep disturbances causing the chronic pain, or the chronic pain causing the sleep disturbances, or are they just together? You're not going to tease those out. So try to improve both. But it starts to beg the question, like, this points in the direction of needing to pay attention to it.
Yeah, absolutely. There's actually a fair amount of evidence that's been published over really the last 20 years. On sleep health, with much more focus in the last decade, but the evidence at this point would suggest that how well somebody is sleeping, so how much and the quality, is likely a stronger predictor to their pain than pain is a predictor of their sleep, which starts to really point at, here we are trying to help them with their pain and get moving better. But if sleep is really driving that, we might be intervening again or starting at the wrong spot. And it makes sense too, right? Think about yourself. Like when you don't get a good night's sleep, how well do you like interact with other people? And I mean, the dark cloud is kind of gloomy over you that day, right? Like nothing's going well, and can't get through my email, and I've had to sit in this meeting, and so said this to me, like nothing's going well. So it makes sense that you're neurologically more amped up when you aren't getting good quality sleep. So it makes sense that if somebody has a pain problem, they're not sleeping well, their pain problem is probably being amplified even further.
I did afternoon radio for most of my radio career, right? Drive time, right? 2 to 7, a lot of phone calls, a lot of concert and beer giveaways. But for 2 weeks in my radio career, I was a morning co-host. And the reason it did not last, I was not able to adjust to a morning sleep schedule. So the other guys in the show were getting up around 4 a.m, get on the air at 6. Now, when they were done at 10 or 11, they were done for the day, but then they had to do appearances at night. So they go home, they'd sleep for a few hours, get up and go to a concert or do a bar gig, and then go back to sleep again. My brain, I realized, said, if you don't get 6 or 7 in a row, it's binary. It counts as 0. So I realized that about myself because I'd walk around the radio station for the rest of the day as a complete ass. Like I had and I was a pretty, amicable guy, but I was a changed person for just a couple of weeks when my sleep quality, because I was so nervous about oversleeping, right? So I couldn't even really sleep when I was sleeping. And of course it got shortened or split up and everything hurt. I mean, I'm thinking back to that 2 weeks and I can still tell you what my elbows and my knees felt like. It just hurt.
Well, I have small children, and when they were kids and little and toddlers, I mean, I wasn't sleeping well for years, and like I was just in a fog. And then finally, when my littlest was old enough to where he was, sleeping through the night in his own room on a consistent basis, it was like this fog just lifted, and I was like, oh my gosh, I can like form thoughts and complete sentences, and it was. I don't even think you realize how you're not feeling very good, in multiple ways, be it pain or, reduced cognitive function or, just not feeling great, right? Until you then start sleeping better and you're like, oh my gosh, that makes such a big difference.
Because you just get it done, whether it's work or, caring for children or caring for loved ones, you just get it done. Like that starts to get pushed back. It's like sleep is a luxury, but we start to realize it's really more of a necessity to function, right? So I wasn't taking a text message on my phone a second ago. What I was doing was I just started wearing the Apple Watch, and one of the features is sleep. So I know for the last 14 days, I've been averaging 7 hours and 30 minutes of sleep, which isn't bad, right? That's actually higher. If you had asked me how long you'd sleeping, I'd say, I don't know, 6 hours. But according to Siri or on my wrist, it's about 7.5. Wearables. How often do you guys, if the patient has them or has access to it, how often are you able to look at that information? And if you're looking, what are you looking at?
You want to go first, Brett? Or
yeah. I'll go first. I've heard Katie's spiel and I fully, support it, and she'll share it in a minute, I'm sure. But I'll say wearables are a slippery slope, and it's not something that I recommend to my patients usually because they can become a source of anxiety. And a lot of patients aren't really interested in the data. Now, you will have some that are interested in the data. They want to it. They'll ask you about it. And then, I'm not opposed to it, but we kind of set up some rules, right? Or we kind of define what it is. I personally wear a wearable. I actually wear this. It's a ring.
What is that, the Whoop?
This is called an Aura ring,
Okay.
OURA. And I've been wearing this now for about 2 years. And for me, I'm a data-driven person, right? I'm going to school and I'm doing research, and so I'm really interested in my numbers. But what's amazing to me is this wearable has really changed my sleep behaviors. So it's bringing mostly a positive spin to my life. And I've gotten in a good habit of, like, if I know I didn't get a good sleep, I just don't check it. Because I don't need that negative reinforcement. Although it can work the other way. Sometimes you feel like, man, I did not get a good night's sleep. And then your wearable actually says you did. And so there's maybe a little placebo there as well. So there's lots out there. They're not perfect. They're not super accurate. So you kind of have to take them with a grain of salt. But if they're helping you change your behaviors, I think they can bring a positive thing, and they're getting better. So that's what I'll say about it.
I'll just interject before we hear. I can't wait to hear what Katie says, because like to see Brett's face, he's like, I don't know if I want to go before. So he's got a thing on this. But I am a complete golden retriever. I'm a Pavlov's dog. I got this. It wasn't planned, but man, especially with the Apple Watch, for me the rings, like the movement ring and the stand up and the exercise, I like to see that damn thing full. So I'm like, all right, can I go take a walk around the block? So I think that's one of those positive reinforcements that you're talking about, which is, hey, I'm setting a goal for 40 minutes of movement or 40 minutes of exercise a day. I can split that up. There's a good positive reinforcement. I actually didn't find the sleep function for a month or two. And then I was like, ooh, how is this going to go? And it actually was better than I thought. But I could see if it was worse than I thought, it might have been a little bit of maybe a little bit of anxiety in there. But I think that's how I am. But I could see where some people, where this is an issue, where that could be an even more of a negative driver. All right, Katie, feel free. Let her rip on this. I can't wait.
I'm kind of wondering what I've said in the past.
No, you did nothing. I didn't mean to set that up that way.
No, I mean, I absolutely agree that there's definitely pros and cons, and I think the important thing is that if you are wearing a wearable, or if you are a physical therapist who is, looking at wearable data that your participants or your patients are bringing in, to just make sure that you're aware that some are not very accurate. They do a decent job of measuring wake, but they're not really all that accurate at measuring sleep. Because if you think about it, like, they're just measuring movement, right? Like, so if you're up and you're awake and you're moving, then it's like, yep, you're awake. But if you're laying in bed, laying really still, but you're awake, it can say that you're sleeping. So they oftentimes tend to overestimate the amount of sleep that you're getting, and also overestimate your sleep efficiency. So another kind of way that we look at sleep quality. So I think you just have to go in with it eyes open with that. But absolutely, the positives is that, one, I feel like I have a lot more conversations with people about sleep, because so many people are wearing wearables now, they'll want to talk about their sleep, which I think is fantastic. So I think using it as a tool, as a conversation starter, is fantastic. And just that people are more aware about their sleep, they want to talk about it. So in that sense, it's an awesome, definitely a pro for that. And then for Brett's point, if it does change behavior, if it does motivate people to do behaviors that are going to help them sleep better, then that's fantastic too. I have seen, a few people that really become super anxious though about their sleep, because they have this wearable on and it's telling them they're getting really bad sleep. And so, but again, I think you just have to talk to those people about, what would you think about not wearing it? And also, educating that this may not be a very accurate assessment of your sleep. I usually like to kind of throw it back of, well, how do you feel when you wake up? Just because your wearable tells you didn't sleep well, if you feel like you slept well and you wake up feeling refreshed, then chances are, that you've slept pretty darn well. So we don't tend to use them for our research purposes. We use research grade wearables called actigraphs, because those have been shown to be valid and reliable measures. But certainly, they're expensive, and they do take time to analyze the data. So I think, in clinical practice, using wearables is great. As long as you kind of know the pros and cons. And I think also, to Brett's point, the technology is constantly changing. There's actually just a paper that came out like a month or two ago, where they were comparing 7 commercially available wearables compared to an actigraph. And they actually found that these, some of the 7 were decently good at assessing sleep. So I think as the technology improves, as the algorithms improve, then I think we're really close to having a wearable that is maybe a little more accurate, and I'd feel more comfortable using it then.
We've come a long way from the clicking pedometer my dad used to wear on his belt when he used to go golfing to see how far he walked. When in terms of accuracy, yes, it was measuring steps, but how accurate? But as these things get a little bit better, so let's go away from the technology and talk about what are optimal sleep behaviors then. Not to go completely away from this, but I set up the sleep app on the Apple Watch, and it does say, hey, you said you wanted to go to bed by 11:25. It's 10:45, so you need to start winding down. And the first couple of times I saw, what, I don't need that. And then after a while, I started to say, yeah, I do need a half hour to kind of start to, get away from the screens or turn off the Netflix and start to, hey, go brush your teeth and start to do all the behaviors I need to do before I go to bed. But, what are the things you discuss with your patients about what are optimal sleep behaviors?
Mm-hmm. Yeah, and I think to answer that question is actually really helpful to know like what are the physiological mechanisms that drive our sleep, because I think it helps to give like the why of why you tell your patients to do these certain things. And so not to to go into major detail, but there's two major physiological processes that drive our sleep. One is our circadian rhythm, which people have likely heard of. Our bodies as humans run on a 24-hour cycle. There's a nucleus in our brain called the suprachiasmatic nucleus that secretes melatonin that basically kind of tells our brain when it's time to go to sleep and when it's time to wake up. And it's really driven by light, so there's a connection from your retina to that area of the brain. Light tells your brain it's time to wake up, and dark tells your brain it's time to sleep. So that's one mechanism. And then the other mechanism is called our sleep drive, or our sleep homeostasis. And that's basically, how long you've been awake, how much activity you've done. You kind of think of it as like a balloon, right? So throughout the day, that balloon blows up, as you're more active, as you've been awake, so that you have really big sleep drive. So then at night, when you get into bed, you fall asleep quickly and easily. And so ideally, you want both your circadian rhythm and your sleep drive to be optimally strong. And not only both of them be optimally strong, but optimally aligned, right? Like, because if your circadian rhythm is kind of on one thing and then your sleep drive's on another, you still could potentially have difficulty sleeping. So we want to optimize both of those systems. And then, Jimmy, to your point, you touched on, the sense of like your arousal system, right? Like, so your sympathetic nervous system, we also want to make sure that is fairly well dampened, especially in the evening time, so that way when you do get into bed, that sympathetic nervous system is fairly low. So that way, then, that great circadian rhythm, your sleep drive super high, arousal is really low, magic happens, you get into bed and you fall asleep really quickly. So the strategies that I use with my patients really center around, those kind of three concepts. And then of course, environment, things like, again, wanting the room to be really dark, having it be cool, eliminating noise as much as possible. So those thinking about environment as well.
So let's talk about things people will do. Like, I don't know, maybe like at 7:30 at night, they record a podcast. Maybe they're drinking a beer while this. And I know, like, I'm 41. I think when I hit like 35, before that, I could drink kind of whatever I want and go to have a great sleep, or anyway I thought I was, and wake up and be fine. Like 35 on, 3-4 beers in a night out with my friends, man, I'd fall right to sleep, but I would sleep like garbage. And like, so I was like, well, I guess this is just what happens when I get older. But what I realized is if I could get some water in me, or if I could drink earlier and give myself some time before bed. So I imagine what I'm getting at is, I'm not looking for you to diagnose me or help me with my sleep. I'm guessing like some of these things come into play, and you have to tease these out for the individual.
Absolutely. Like, so every patient that I work with, as I'm taking kind of their subjective history about their sleep issue, I'm kind of funneling it into these buckets, right? Of, okay, that falls under circadian rhythm. So focusing on things like regular wake up time, reducing light in the evening, increasing light in the morning, and then I'm funneling into that bucket of sleep drive, so if they're sleeping in, or they're laying in bed for a long time, they're not very physically active, they're taking naps, those are all things that go into the sleep drive funnel. And then in the arousal funnel, if they're not winding down in the evening, maybe they're just kind of more of an excitable, anxious person, so I'll funnel that into, okay, we need to talk about that. And then kind of these general sleep hygiene things. So Jimmy, like you talked about, alcohol, right? It is a stimulant, right? Well, no, I should rephrase that. It's a depressant. But if you're drinking it, especially in larger quantities, yes, absolutely, it will help you fall asleep, but it's going to disrupt your sleep. So you're going to get less optimal sleep staging.
Yeah.
And then nicotine is a stimulant. So, sometimes having a conversation about that. So, so I kind of funnel it in those different buckets. And then, of course, also the environmental factors to talk about. So that's kind of how I strategize, when I'm working with patients about kind of how to cover those different topics for those different individuals.
I just love how many questions you've probably put in the audience's head of, because I mean, we started off with just like how long and how well, but now now in the last 5 minutes, I feel like Katie has just like rung so many different bells in like terms of the different areas and things that you could be asking, because they all add up to the end equation of how well or what the outcome will be in terms of recovery during sleep. Now, how about this? Weekends, right? Because we typically have a Monday through Friday regular schedule. And then on weekends, myself, maybe some other people might stay up a little bit later. What do you suggest on weekends in terms of not changing that regular circadian rhythm so much that by Monday you're fighting to get back into it? Like, how does that come into play?
So I mean, like everything, it kind of depends. Like if you have insomnia, then I'm very strict. I encourage you to be very strict about your wake up, and having a very regular wake up time. But if in general you're a decent sleeper and you want to sleep in on the weekend, I really have no problem with that. Ideally you'd keep it within like an hour. Anything more than that, you run the risk of disrupting your circadian rhythm. I mean, you can almost think of it as like, traveling across time zones, right? Like, so if you're sleeping in for 2 hours, you're traveling across 2 time zones, and then you've got to travel back, by Monday morning.
Yeah.
And so I think, people kind of can relate to that. A lot of people have traveled, gone across time zones, and they're kind of like, okay, yeah, I kind of get that. But at the same time, I mean, I'm going to admit this, live on air, that, I like to sleep in too, and my natural circadian rhythm, I'm more of an evening type person. Like, I am not a morning person. And, the coronavirus and, working from home, where I have had a little bit more latitude in my schedule, like, I would prefer to go to bed later and sleep later. And so I think, some of us we just kind of have that shifted circadian rhythm. So, yeah, as long as you kind of know what you're getting into, but absolutely, if you have insomnia, you're having difficulty sleeping for other reason, then really the recommendation is to really have a very regular wake up time, because that really does help train that circadian rhythm. So that's a really important piece for those individuals.
Yeah, good advice. So an hour. All right. So at least that be something to aim for. Nick asked a great question in the comments. He's bringing in some different things that are now available over the counter. And I kind of asked this really briefly before we hit record. Nick's asking about CBD or melatonin. I know I've got like these grape gummy bears that a friend gave me when I mentioned this past summer I was having trouble staying asleep. I have no problem. I could fall asleep on a train, a plane, an automobile, not driving in the passenger seat. So I have no problem falling asleep. But, so where do these things come in? The CBDs, the melatonins. What does the research say, or what do you guys say? And I feel like it depends, or there's some research needed on this coming into it. But, practically, what do you begin to talk about with patients when this gets brought up?
I'll tackle it 2 different ways. Let's start with maybe the melatonin first. I think the big thing with melatonin, and especially because it's, if you're taking it from over the counter, so it's a supplement, so it's not regulated like medication is. Of course, there is prescription melatonin as well, and that is, of course, regulated. But the issue with melatonin is that there was a study that was done that, looking at different supplements of melatonin, that the potency of melatonin varied a lot depending on which product you were taking. So, it may say you're taking 5 milligrams when really you're taking 0, or you're taking, 100. Wow. So that, I think that's something to be really cautious about. And then the other thing is that, people tend to take too much. Like, most of the over-the-counter melatonin comes in 5 milligrams, and really the recommendation is to start at like 0.5 to 1 milligram, and then gradually increase if needed. The other issue is people tend to take it at the wrong time. A lot of people take it right before bed, and really the optimal time to take melatonin is 2 to 3 hours before the time that you want to be falling asleep. Because, I mean, if you think about it, you have to ingest it. It has to get in your bloodstream. It's got to get to your brain. It's got to supplement your natural melatonin production. So those are really kind of big issues. And then I guess maybe the last other big thing is that, I think people, it's overused. Really, the evidence for melatonin, as far if people are just having difficulty sleeping, or if it's insomnia, the recommendation is not for melatonin. Really, melatonin has been shown to be effective for those people who have a circadian rhythm shift, so either too early or too late. So really the melatonin is helping to regulate that circadian rhythm. So if you don't have a circadian rhythm issue, chances are that you really don't need to be taking melatonin. And then I guess, sorry, I'm going to add one more thing. Then the other thing too is it becomes a crutch for a lot of people, and so, I think people tend to take it because they want to be sleeping better, but oftentimes really where the effort would be best spent would be to be addressing some of those behavioral issues around sleep. And then also if addressing some of the negative thoughts sometimes that people are having about sleep. And then with CBD, that there is some evidence that CBD perhaps can help people sleep better. But the evidence really is not that great right now. The studies that have been done have been really small sample size. And so I don't necessarily recommend that just because the evidence is so low at this point. I would anticipate that more will be coming out though, probably as we speak.
Yeah.
One more too, and just the expense. So as Katie talked about, it oftentimes leads to people creating dependencies. And these supplements they're cheap if you buy one bottle and you take it a few times, but over time, I mean, you're talking $15 a bottle that they're going through on a regular basis. And so now you're adding expense, to somebody else. So I always look at that component as well for our patients.
All right, we'll start with Brett, and Katie, feel free to jump in on this one, because here's where the rubber meets the road for physical therapists anyway, I think. What do patients currently believe, or what is the belief structure in the clinic about sleep when a patient comes in about a musculoskeletal condition like back pain? I'm here for my back, and my doctor said something about a sciatic, or it's my shoulder and a rotator cuff, and you're asking me about sleep. I just feel like, did you read the chart? Did I click the wrong box? So what is their belief as they're coming in? And then how do we flip that around? Hey, we're just asking because this could be contributing.
This is a great question, Jimmy, because this is actually what's fueling some of my research right now in my DSC studies. And there isn't much or any that I'm aware of. Katie may know of some, but in physical therapy research, there isn't much published or known about what patients believe about sleep. So that's what the study that we're looking at right now. We have 7 or 8 different sites all across the US where we're collecting a kind of single time point survey study as people come in to physical therapy for back pain. And we're questioning them about how much they're sleeping and their quality of sleep. We're questioning them about their pain. We're using a scale called the dysfunctional beliefs about sleep. So it's asking them questions about what their beliefs are about sleep. And then we're also measuring just their sleep disturbance with the PROMIS measure, which has been kind of maybe a new, modern, more research-based measure that is used to look at sleep disturbance through, a questionnaire. So at this point, it's really interesting that we're still midway through data collection. We've got about 70 cases, and the beliefs are all over the place. And what I find super fascinating so far, and this is still ongoing, is the amount of hours people are sleeping. And not to take us off the belief question, but I don't think a lot of people understand the connection between sleep and pain and overall health. And 90% of our participants that we've collected data from so far are getting less than 7 hours of sleep per night. 90%. That's so there is clearly a disconnect between the importance of sleep and their overall health.
Well, we can go further off the belief question, but kind of like coming back is like we sort of wear lack of sleep and grinding almost like a badge of honor. I mean, like when I was young in my radio heydays, it was like, how many hours of sleep you get? I did an event late and then did a morning, and it was almost like I'm putting in the work. But really long term, you're just burning the candle at both ends, and you're going to grind yourself down, and you're not going to be useful for anybody, including yourself. Katie, when you're looking at that, when I ask, let's go back to that belief question, because I got more, but that belief question, what do you typically see, or as Brett alluded to, there's not much out there?
There's not, and I think it's fantastic that Brett is doing this research and doing this study. I mean, I'm super excited to see what you find. I'm not terribly surprised that the beliefs are probably, across the board. I think, Some people are super excited that, their therapist is asking them about sleep because no one else is, and they're finally glad to have somebody to talk to answer their questions, to provide education, so I think, that's like best case scenario, right? People who are ready to hear this information. And then I think there's people kind of on the other end, people who are like, oh yeah, I get 5 hours of sleep, but really I'm fine. It doesn't affect me at all, and they're really not open, and so I think then it becomes to, where are they in their interest of changing their behavior, and so maybe they're not terribly open in changing their sleep behaviors at that time. And that's okay. They are in charge of them and their sleep. And, I think sometimes building that rapport and, helping them feel better in other ways, sometimes it opens the door to that conversation about sleep. But I do definitely see kind of those different camps of people. In my work, people are seeing me because they want to sleep better, and so I'm in that fortunate position of, people are seeing me because they want to hear this information, and they want to be in these programs. So I definitely get people who are very motivated to change their sleep and to really start sleeping better. But I'm really excited to see Brett's, studies. And I think, Brett, you kind of talked about, I think there's a lot of opportunity, right? Like if there's such a huge percentage of patients are having sleep issues, like what a fantastic opportunity for physical therapists to have those conversations. That makes me super excited to think about, gosh, if we have more physical therapists talking to their patients about how they can be sleeping better, and of course, referring as needed. I see this as an amazing opportunity for us as a profession.
Yeah, I think for the patients likely who might not see the connection, you might lead them to a possible connection. And for those who already see a connection, you're just gonna, really, I think you're just enhancing a therapeutic alliance there. This person is paying attention to more than just my knee or my back. Oh, we're really doing a whole body thing here, huh? And I think that can only really elevate the perception of the profession in the patient's eyes. Was there
Absolutely.
anything I didn't ask, or any topic that I didn't bring up that you guys would want to get into?
I maybe along that lines too, as I think we're seeing, too, just a change in like just culture, right? Like I think that there's more research coming out, that you can barely open up like Google News without there being some story about the importance of sleep. So I think that it really is changing, the public's perception about sleep and just the awareness about sleep, which, I think makes our job even easier as far as having those initial conversations.
Yeah. When people see things, right? So it's almost like you follow the money, right? So now there are these supplements on the shelves and the wearables are looking at sleep. So now there's attention on it. Can we use that and take advantage of that attention for good? Can we use our powers of science to take hold of this attention? I think we can. I think both of you on the show are two examples of that.
Absolutely.
I love that. I'll be doing more of this. I'll be starting. All right. So I'll need to start to winding down a little bit early in my own personal life and bring this up though. Anything that you'd suggest? You guys had mentioned the validated outcome measure. Any other clinical tools that clinicians might be able to use in practice about sleep that you would suggest?
The Pittsburgh Sleep Quality Index is a fantastic, it's a longer one, so it's used in research, but it's also used in clinical practice. Honestly, my go-to resource is one that Katie published for the home health section. So maybe Katie, I'll let you share that, because that right there is like a gold mine, and that all physical therapists need to have it. It has a decision tree. You can literally walk through and say, what do I do with this patient and their sleep dysfunction?
Yeah, let's hear about that.
So I do have to give Ken Miller credit, because I had written that PTJ article about, these different sleep tools, and he approached me about having this opportunity to develop this toolkit for the home health section. I was like, absolutely, I will do that. And he suggested, what about a decision tree? And I'm like, oh my God, that's brilliant. How come I never thought of that? And so, yeah, we developed this decision tree, and we like to think it helps clinicians kind of, ask the questions, and then based on those answers, guide them to kind of different points. We incorporate the insomnia severity index, which is a valid and reliable measure to look at insomnia, the stop bang if they might have sleep apnea, a restless leg syndrome scale. But I also want to recognize, that we are not, we're not, board certified in sleep medicine physicians, and there's like 100 sleep disorders. And so I don't think it's reasonable for physical therapists to know all 100 of them, but I think we can certainly screen for those top 3, and then certainly recognize, if they're still having sleep issues, despite all my fantastic PT interventions, then obviously referring as needed, and to Brett's point, the Pittsburgh Sleep Quality Index is a wonderful tool to look at sleep quality. It is a little long, it's kind of clunky to score, but there are some kind of faster versions and some online versions that people can use. The Epworth Sleepiness Scale is another great one that looks at daytime sleepiness. I like sleep logs. I think those are really helpful, both as a clinician, but then also really eye-opening for the patient a lot of times to be able to kind of track their sleep. And of course, wearables, if you have an actigraph or, if the person has a wearable, then certainly kind of capitalizing on that data that you're getting from there as well.
To tie it all together, Katie, the list that you just went through, saying that we are not, in fact, sleep medicine professionals, but give a nod to the American Physical Therapy Association, and they put out a House of Delegates position the role of physical therapists and the American Physical Therapy Association in sleep health. And it said just that. The bullet points: screen for sleep dysfunction, identify impairments related to sleep dysfunction, implement and progress therapeutic interventions, educate society, patients, and clients, monitor, and then the most important bullet there at the end, refer to sleep medicine professionals as indicated. So the APTA chiming in with the topics of sleep as well.
And Brett really gets credit for spear driving, getting that position to move forward. Like he led the team to get that written and to bring it forward. And so I appreciate the efforts that he put into getting that position passed. Was a lot of work.
What'd that mean to you, Brett, when you saw the House of Delegates, the profession talking about that and then passing it?
Yeah. So the quick backstory on it is there was mention of sleep health in the health promotion, position statement. And in 2019, the House of Delegates was really cleaning up a lot of language. And unfortunately, it just got cut because it was a long laundry list item. I happened to be serving on the Washington delegation and recognized it after the fact. And I said, wait a minute. In 2019, we also passed a very similar motion for that, similar to the sleep one, for diet and nutrition. So here I am, I'm going, okay, health, we need diet, nutrition, movement, and sleep. Okay, great. PT, we've got the movement thing covered. We now have a great position statement for PT's role in diet and nutrition. Where's the sleep, right? And it literally didn't exist after 2019. So there was like a year gap. And so recognizing that through my work at Bellin College and, some of my collaborators there, Mark Shepard and Chris Dickerson, we quickly, wait a minute, I got to do something about this. So brought it up to the Washington delegation and we said, hey, we've got to collaborate with Katie and the Kansas delegation, AJ and Stacia there were fantastic to work with. And so that's kind of how this thing was born. Of course, with input from people like Janet Besner, et cetera, who are also kind of working in that space. So very much a collaborative effort, but super excited to be sitting there in the House of Delegates, virtually in 2020, and to see that unanimously pass. So it was fantastic.
And I, in some ways, it ended up being kind of fortuitous, right? I mean, because I had no idea that it was taken out of that one position statement until I think it was Chris that mentioned that. And I was like, wait, what? I had no idea that sleep health was taken out. And so, I mean, really, yes, that was a bummer. And I think it was unintentional, but I think it really gave an opportunity, to really highlight the importance of sleep health, and so some ways it's like, this ended up being a great thing because now we have an entire position statement completely, centered on sleep health, which I think just really speaks to the importance of it within our profession.
Yeah. Well, thanks for keeping your eyes open and paying attention for stuff like that there, Brett. We need that.
Absolutely.
All right. You guys ready to do 3 questions?
All right.
Doesn't matter. We're doing it anyway. Let's do 3 questions. 3 questions brought to you by our friends at Fusion Medical Staffing. Happy travel PTs start here. As a travel PT or PTA, you get to decide where, when, and how you do what you do best. provide quality care to your patients. With a traveler-first mentality, it means you get full control of your healthcare career so you can create the travel lifestyle you love and deserve. And with detailed job transparency, you can seriously choose your own adventure, just like those books that I used to cheat on when I was in middle school. Start your adventure at fusionmedstaff.com. That is fusionmedstaff.com. You guys are giggling. You used to cheat on those books too, right? You'd be like, turn to page 48 for that. I just keep my finger in the back one and be like, no, I'm going to go back. So, but you can do that. So again, choose your own adventure. So 3 questions. We'll go Brett and then Katie. First question is a where question. So once it's safe to travel, you can freely move about the country. Where's somewhere in the 50 U.S. you wouldn't mind going, Brett?
Going to Hawaii.
Going to Hawaii. Katie, what about you? You're in the Midwest.
So we're actually going to Utah in April. It's been on my bucket list of, going to the national parks there. So yeah, we're going to do a 2-week trip out to Utah.
Hawaii, Utah, they have people there, which means they need physical therapists there. So again, fusionmedstaff.com. Second question is a what question. What's something that you have watched, read, or listened to, a book, movie, podcast, something that you think the audience would just gain value from? Can be PT or non-PT related, doesn't matter.
Angela Duckworth's book, Grit. Fantastic read. And with 2 young children in my home, I was surprised to find out that I was reading a book about raising children, which was fantastic. It was a pleasant surprise.
I'll give her a nod too. She does a podcast with Stephen Dubner, who does the Freakonomics podcast. So now it's Angela Duckworth and Stephen Dubner, called No Stupid Questions. And they're so conversational, but then but she's like heavy research based, and she'll make research, dare I say, fun and applicable. And they're using a lot of social science research, obviously because she's writing a book like Grit. But their podcast by NPR, No Stupid Questions, very well done. Angela Duckworth, really good. Katie, what's something the audience could watch, read, or listen to?
Well, I'm going to have to say Why We Sleep by Matthew Walker. That's my go-to. He's done a ton of research on, sleep and learning, and especially memory formation, but he does a fantastic job of taking that science and that research and distilling it into, accessible information. And so for a lot of my patients that are interested in learning more about sleep, I oftentimes will recommend that book to them as just kind of an add-on for some interesting information about sleep.
That accessible, huh? So a patient, That's great. I love that. Yeah, that book has come up a couple times. I'm gonna have to throw that on the old the queue to get that. Last question that we ask is always about people. Brett, who is someone the audience should know more about?
Somebody the audience should know more about. Oh my goodness.
A chance to give someone a nod, they're flying under the radar but doing great stuff.
Yeah, I'll give Mark Shepard at Bellin College. So I'm obviously collaborating with him, but he's also the fellowship director of the OMPT manual physical therapy fellowship there at Bellin College, and he is doing some fantastic stuff currently. So give him a nod.
Love it. All right, Katie, who do you got? Who's your who?
I'm going to give a shout out to my colleague, Stacia Trzynski-Brown. She's on the Kansas delegate. She helped to move forward the position statement. I'm also giving her a shout out because she also helps to run our student-led PT clinic. That's been shifted completely telehealth. And so it's just done a fantastic job with being able to pivot very quickly with COVID, and has also then created, clinical opportunities for our students that have maybe been displaced because of COVID issues. So she's doing really amazing work at KU Med.
Doing some really tough stuff in a really in a regular time, never mind in a difficult time. That's tough stuff to do. So that sounds well deserved.
Jimmy, I got to give one more nod to Jenny Jordan, who is the chief delegate of Washington, who I failed to mention, and she was also a huge part of making this all happen. So she was really the person to organize and connect behind the scenes and help craft language. So want to give her a nod too.
Perfect. All right, that's 3 questions again brought to you by our friends at Fusion Medical Staffing, fusionmedstaff.com. Now it is time for the parting shot. Parting shot brought to you by our friends from the Academy of Orthopedic Physical Therapy. They know you want to be a confident, up-to-date orthopedic PT. In order to do that, you need an easy way to get the latest information so you can best treat your patients, right? That's it. Problem is, new information coming out every day, and you might not have time to keep up with all of it, which could make you feel overwhelmed and left behind. Maybe you don't know where to start. They get it. They know what it's like to feel like that, and that's why they created Current Concepts of Orthopedic PT. All right, that is one of the best resources to use. Maybe if you want to go and take that OCS exam, or you just want to level your ortho game up. To get it, go to orthopt.org, register for Current Concepts of Orthopedic Physical Therapy, and begin your journey to being a confident and up-to-date orthopedic PT. Again, Current Concepts of Orthopedic PT at orthopt.org. Really, it's your chance for that mic drop moment, the last thing you do. So we'll go Brett, and then Katie. Katie, you'll be the ultimate close. What do you want to leave with the audience as we wrap up today's episode there, Brett?
I just hope that everybody has enjoyed this information about sleep and kind of recognizes the role of the physical therapist, and that we can play in, improving sleep health for our patients and for society and our communities.
I think it's a big deal, right? Especially with APTA jumping behind that and saying, no, we're going to plant our flag in this. This is something we need to pay attention to. We're going to put the words behind it. Katie, your parting shot for today.
Yeah, I mean, I would just kind of reiterate that, I think, recognizing our role in the promotion of sleep health. If you're not really sure kind of where to start or have those conversations, there's a lot of really great resources out there. I'm happy to connect, and I imagine Brett would be too. But just start having the conversations. That's, I think, the very best and the very first step, and happy to share resources.
Katie and Brett, thanks for coming back on the show. Next time, of course, I'm going to be wearing the spandex Spider-Man outfit just why not? I mean, we're not going anywhere for a while. Might as well just break that out of the closet. But thanks for giving us some real tactical advice, big picture and little picture on sleep and why you should be talking about this more with yourself and, of course, with your patients. So thank you guys so much for your time.
Thanks for having us.